So again, today's topic, coding and documentation programs going beyond compliance, and we'll mention what the implications of that are and why we entitled that as we go through. Hopefully this will be enjoyable for you. We are setting these up in a sequence where we look at, very often organizations will ask, what's necessary for us to do? What will you do? What are the deliverables? And what can we expect if we engage you for this type of work? So we figured we'd do two things. One is give an overview of what we feel a comprehensive coding and documentation audit and education program is, but also indicate if you do engage with us, what that might look like. So many organizations will say, well, of course we look at coding and documentation. We have a corporate compliance program, and they do chart reviews once a year, and we have a coding audit program based on our corporate compliance concerns. But what we find with most of the physicians, APPs, and other direct care providers we interact with is they say, I'm not really confident in my coding. I kind of learned as I went, and I'm not really sure, how confident I feel about any of the coding that I do. And yeah, we have the corporate compliance program, and once a year I hear I did okay on my 10 chart review, um, but I'm not sure how to improve what I do, and nobody can tell me how to improve what I do. So, promoting accurate, complete encounter documentation and appropriate encounter coding are fundamental factors for maximizing and having a positive impact on patient care revenue, provider productivity monitoring, financial sustainability, and again, with provider productivity, the direct impact on provider compensation, since many of the compensation models out there are productivity based. And then also address corporate compliance as opposed to only address corporate compliance. As we look at that element, we do need to reiterate that the individual that renders the care is ultimately responsible for the code that's assigned to the encounter. Whether it's done by the individual, him or herself, or done by a certified coder, in the process of the claim submission, the direct care provider remains responsible for the code assigned. Many organizations assign responsibility for the coding to the individual provider that rendered the care. If that's the case, it introduces very many different factors that could lead to wanting to develop a comprehensive coding and documentation program. So, for instance, when looking at the E&M and CPT codes that the providers enter for the encounter, is there a regular audit for accuracy, and more than what we talked about, the corporate compliance 10 charts once a year? Do they receive feedback on the accuracy of their coding selection on a regular basis, just as the audits are done on a regular basis? Do they know how they compare to their peers and external benchmarking endeavors? And are they educated in how the documentation might be improved to more accurately capture the effort they expended and the care that was rendered? Meaning, have they accurately captured the complexity of the patients they're caring for so they can, I hate the word justify, but justify the time spent and their concerns about their schedule and productivity concerns? So if you can answer any of these questions that we just talked about as no, then there's likely an opportunity for improvement and having a greater impact with the program. So if we look at the data acquisition process, two levels to look at. The first is when we want to look at external benchmarking. The external benchmark tends to be the CMS coding profile. And for that, we look at CPT reports by provider for a full year. That gets rid of, allows for ample number of encounters to look at, takes into account seasonality, takes into account variability in provider scope, and those types of things, and determines trends in over or under coding. So to explain what we mean, we come up with a CPT report, and it'll show the numbers of encounters or percentages of encounters that might span the office-based codes of 99211 to 215, and then compare that to the CMS coding curve and overlay the two to see how the individual compares with the national coding profile of their colleagues. The second element, and by the way, that part of it can indicate whether there's a focal area to investigate or explore further. But we get into the larger part, and that's a detailed coding assessment. And that requires assessments of the actual documentation compared to the assigned E&M and CPT codes. We found that that's best accomplished through direct access to the EMR as opposed to trying to have copied notes, because often when you're looking at complexity and what was looked at, you have to get down into the data that was looked at. So looking at actual imaging reports or laboratory reports, medication profiles and the like. And so as the detailed coding assessment is done, the coding auditor goes all over the EMR to make sure that the data that's being looked at is inclusive and comprehensive. What happens with that data? Well, we already talked about the CMS coding curve comparison. So we're looking at the individual's coding for the various types of encounters: office-based, established, office-based, new, inpatient as applicable, preventive services, those types of areas, and compare it to the corresponding CMS coding curve to see how the individual lines up with the CMS benchmarks. It can be done both individually, but aggregate by specialty, and you can, again, look for areas that might warrant further investigation. As we look at the individual chart review process, the raw data gleaned is collated into, or the data are collated into a spreadsheet with pertinent comments, RVU comparisons, meaning what RVU value was attributed to the originally entered code versus the suggested code, and that can then look at potential revenue impact, either potential additional revenue opportunities, but also if the individual is overcoding, where there might be a negative impact on revenue if the coding was more aligned with norms. So on our end, the chart audits are conducted and analyzed by certified coders, and we also have certified auditors that look at the information and make comments and suggestions. These then develop audit reports, which we'll show you a sample of in just a minute, that summarizes the detail, and a second report that shows the actual raw data, so we can drill down into each of the encounters that were reviewed and what the specific suggestions would include. A difference from what you may have experienced before is we also try to focus on suggestions to enhance documentation. On the one hand, we have coding that matches documentation, but perhaps the documentation could be adjusted a little bit to better represent the care that was rendered. We also try to inject clinical expertise into the process to ensure individuals are aware of the context of the audit, its analysis and interpretation is clear, accurate, and conveyable, meaning it's sometimes nice to have somebody who's not a coder involved in the reporting process and the educational process. We talked about the coding curves that can be by individual specialty or aggregate of the employee network. And then the individual audit reports we talked about as well. So how do we deliver that? The first element is an initial provider education session that provides general coding information to the group to level set. As we mentioned, many of the providers we interact with indicate a deficit of knowledge related to coding and documentation. And so this tries to level set a little bit to give general background and provide that initial educational review. As we review the individual chart audits with organizational leadership, it allows us to discuss opportunities for revenue enhancement versus where there might be revenue risk based on the coding outcomes, and then provide individual provider feedback sessions. So the individual provider, based on adult learning, can see the work they actually did, what suggestions for improvement might be made, and then follow up to see if the interventions made a difference and to re-emphasize and reiterate the suggestions from the initial interactions. So we mentioned an overall report. So with individual names blocked out, this is a sample summary report for a breast surgery practice within an employed provider network, how each individual scored, how many charts were reviewed, what the RVU opportunity would be if they were undercoding, and then what financial opportunity that would represent for these 25 encounters that were reviewed. Within that overall summary are some specifics that might be noteworthy. So for instance, there was a nurse practitioner that had 13 E&Ms undercoded by one level, which accounted for the largest element. She was actually the initial one reviewed, which had the RVU opportunity of about 11.5 RVUs, representing about $600 of net patient revenue. And then one of the documentation suggestions is that the physician in the practice, a physician in the practice, if that individual was independently reviewing and interpreting images and not just saying the radiologist said, but on my review of the image, it looks like da-da-da-da-da, then several of a level 3 interaction would become a level 4 interaction with that documentation. So just, one example of where suggestions can be made about documentation enhancement. The individual report looks a lot more busy. So each of the encounters that are reviewed are outlined. The E&M or CPT code that was assigned on the original was listed. The auditors suggested E&M or CPT codes are listed and specific comments made. So this gets down into a detailed level. And this is the level that would be really reviewed with the individual provider. And there is the opportunity in those circumstances to actually look at the encounter documentation by bringing up a shared screen EMR view and going down through and saying, here's a difference where a little bit of documentation change might, it would seem like this is the care that was rendered, this is the care that was documented, so this little bit of documentation change might garner a little bit advanced level of E&M coding for the encounter, and therefore increase revenue, increase RVU attribution, increase provider compensation, et cetera, without any risk of compliance. If the individual is overcoding, that leads to a different discussion. Your documentation does not seem to match the E&M code that was assigned. And here's what could have happened with the documentation to meet that level. Did those things actually occur? And so again, it leads to a dialogue type of feedback with the individual and the opportunity for individual education. As already mentioned, we feel that follow-up reviews are key because it re-emphasizes and reiterates educational points made in previous feedback sessions. It also allows for more focal look at things. So there might be an area of the individual scope of services that might merit a deeper dive. And so each of these can be looked at sequentially over time. Most of the follow-up reviews are have less numbers of encounters reviewed. Initially, we often recommend 25 to get an opportunity to look at as broad an aspect of the clinical practice as possible. Often in follow-up, the slide says 10, but it would be 10 to 15 encounters. So a little bit less. It can be, again, focused. And if we're looking at primary care across all aspects of primary care or other specialty care, along all aspects of other specialty care as well. The other factor is it's great to start with our existing providers and build them up, but you'll have new providers join the network on a regular basis. And so, starting fresh with these folks, as new providers come into the organization, start with an initial educational session early in their process. Often we recommend this during their normal orientation sessions. And then follow that with an initial audit of 25 encounters during their initial 6 weeks with the organization. And that gets an early opportunity to look at their performance and intervene early in their association with the group. And then the cyclic reevaluation occurs thereafter. So that's an overview of what we would look at as a comprehensive coding and documentation audit and education program. Hopefully it gives you an idea of the background of why we think it's important, what the opportunities might be in undertaking a program like this, and how it might be delivered. And so with that, and again, we want to give full recognition of your time. But with that, we'll open up for questions.
Thanks, Terry. And as a reminder, we do have that poll up. So if you want to go ahead and submit your response there, we've got a couple of questions. The first one that we're seeing is, how can we incentivize our providers to document and code accurately? Which I know that's a big question that we've heard at different conferences, and just kind of an always looming question. So I'll pass that off to Terry.
Yeah, so and that's a great question, because it's one thing to say we have this program, but how can we incentivize folks to improve? I think one of the things that we mentioned already is if they're on a productivity-based comp model, the better they document the care, the more accurately appropriate codes are assigned, the more their compensation can be optimized. How's that for selective choice of words? I would say the more money they can make, but if they're over-coding, that actually hurts their pocket. But by the same token, there is a little bit of incentive with that. What we've found over time is that individuals that are on a straight compensation model not only are not incentivized to see more patients, they're not really incentivized to accurately document and code, right? So they straight salary tends to reinforce minimal behavior, meeting minimal contractual requirements, making sure you did the documentation, the baseline that you need to do, that type of thing. And so what we found is individuals on a straight salary model tend not to code and document as well as compatriots on a productivity model. Having said that, just because you're on a base plus incentives model with a productivity incentive based on RVU generation, if there's not downward risk or risk of downward adjustment of the base and you have a guaranteed base, that can behave very much like a straight salary model. Because if the individual is not incentivized to earn more with bonuses, there's no disincentive, about not meeting base threshold expectations. In looking further than just, incentivizing straight productivity, if we look at non-productivity incentives related to coding and documentation, it can include things like timely response to coder queries, where the coder may disagree with the assigned code by the provider and say, we think the code is a 99213 instead of a 214, and the provider then has the opportunity to answer the query and indicate why they thought, and that can lead to a back and forth dialogue of, well, if that's the case, you didn't say that, you need to say this. And so timely response to the queries can be one of those secondary proxy things that can be a non-productivity incentive. And the other is coding accuracy. So, if just like in corporate compliance, if you have a baseline um, coding proficiency that you expect, let's say an 80% or 85% expectation, a non-productivity incentive might be to achieve 90 or 95% or better on your coding and documentation audits, that type of thing. And so you can get there either with the productivity incentive, more accurate RVU generation and more accurate comp, but also in the non-productivity incentives. One thing we would caution on is avoiding revenue kind of incentives, because they have been interpreted as you're just trying to pay them more or give them a kickback to have the organization get paid more. So again, we'd stay away from revenues and more on process and other metrics like that.
All right, we've got one other question that came through. And I will say as well, what I'm seeing so far from the poll is that we've got a couple of folks who don't know the current status of their provider documentation and coding audit and education program, and that we've got one person saying that they conduct coding audits associated with an annual corporate compliance program. So the other question that we came in, coders assign codes for our providers' patient encounters before the claims are submitted. So do we really even need a program like this?
Oh, and that's a really good question. The one thing that having certified coders review the documentation prior to submitting the claim is that you're going to be assured that the assigned code matches the documentation that's there, right? So the compliance risk goes away because you won't have overcoding, but you do still risk undercoding, right? Because since the code is based on the documentation, if the documentation is suboptimal and doesn't accurately reflect the degree of patient complexity, then you might end up undercoding the care that was rendered because it wasn't captured well. And so again, back to revenues left on the table, provider productivity left on the table, and likely if that program is like most of the programs we see that have coders enter a code prior to claim submission, providers tend not to get feedback at all about their documentation, right? So it's whatever's sent in, it gets coded, the claim goes out, and we get paid, and that's the end of the story. So you don't have that documentation integrity or documentation improvement aspect, and so you'll tend to always function at the same level, and there wouldn't be an opportunity to improve performance across the board. So it's great on the compliance side because you won't be overcoding. It's not so great on the revenue side because you do risk leaving money on the table, and it's not helpful on the performance improvement side, and because providers aren't getting any feedback, it's just whatever they submit is being coded and sent out. Now, if there is the opportunity to provide documentation feedback, then that can be beneficial. So if the individual doing the coding not only does the coding, but provides individual educational feedback to the provider, and I don't mean just sending an email or a comment and, sitting down with them and actually saying, we've seen this trend, or, if this one encounter, if you had said this, it could have bumped you up a level. And I say, well, so what does that mean? It means the organization gets more money? And I said, well, no, if you're going to, give you greater productivity, for instance, and more credit and perhaps more income. Because remember, we're all in it. We're all going to ask what's in it for me, right?